Hello everyone, hope you all are doing good. So today has been a long day for me and I'll be trying something new now. I'll be taking you through some of the cases that I've seen today in my center, and we'll be seeing the reports as well as some teaching points related to those cases. So starting with our first case, so here we have a 40-year-old female who presents with palpitations, and these are the CCT thorax for this patient. She had initially gotten an HRCT where we saw some tortuous opacities, that is vessels in the right lower lobe of the lung, and to determine the cause we actually got a CCT thorax done for this patient. So these are the CCT axial sections. I'm scrolling from cranial to caudal direction. The main pathology is in the mediastinal vascular structures. So this is the arch of aorta and this is the pulmonary artery. Here we can see that the left atrium, the right pulmonary veins are not seen draining into the left atrium. This dilated tortuous vessel is seen in the right lower lobe of the lung. Again, if we trace this tortuous vessel, we can see that it is draining into the IVC. There is mild volume loss of the right lower lobe along with some mediastinal shift to the right and dextroposition of the heart. So these are the maximum intensity projection images where again we can see this vessel draining into the IVC. This tortuous vessel draining into the IVC, which resembles a sword. So this vessel, anomalous vessel draining into the IVC along with some volume loss of the lung and mediastinal shift. What do you think the diagnosis is based on these findings? The dilated tortuous vessel draining into the IVC looks like a sword. That's a clue to the diagnosis. It's like a scimitar. So actually the diagnosis is scimitar syndrome. On the axial post-contrast CT scans of the mediastinal and the lung windows, we saw some mediastinal shift to the right along with reduced right lung volume and cardiac dextroposition. It was dextroposition and not dextrocardia because the cardiac apex pointed to the left. There was anomalous venous drainage from the right lower lobe to the IVC just before its confluence with the right atrium. That is the scimitar vein, and the scimitar vein was dilated and tortuous. And there was absence of normal right-sided pulmonary veins, which you can see by scrolling back in the video. So what exactly is Scimitar syndrome? Scimitar syndrome, also called hypogenetic lung syndrome, is characterized by a hypoplastic lung that is drained by an anomalous pulmonary vein into the systemic venous system, that is the IVC, and it's a type of partial anomalous pulmonary venous return. And the combination of pulmonary hypoplasia and partial anomalous pulmonary venous return, almost exclusively seen on the right side, is characteristic for Scimitar syndrome. Hemodynamically, there is acyanotic left to right shunt, and anomalous vein usually drains into the IVC most commonly, but it can also drain into the right atrium or the portal vein. And in some variants, the abnormal lung segment may receive the arterial supply from the aorta or its branches. So an important complication for Scimitar syndrome is development of pulmonary arterial hypertension or cyanotic heart disease. So coming to our next case, here we have a 45-year-old female post-right mastectomy for breast carcinoma who's presently receiving radio and chemotherapy, now complains of cough and dyspnea on exertion. She also complained of dysphagia, and this is a CCT thorax done for this patient. So initially she had gotten a chest radiograph where we saw some opacities in the bilateral lung fields, and based on that the clinician suspected metastasis. So hence a CCT thorax was ordered, and these are the CCT thorax lung window where we can see that these opacities that are seen the lung field along with some fibrotic changes and interlobular septal thickening in the bilateral lung fields, particularly on the anterior subpleural region on the right side. This is the post contrast mediastinal window. I'm scrolling from cranial to caudal direction. We look at these opacities, these are non-enhancing. Along with some fibrotic changes, these opacities are actually not enhancing. and there is interlobular septal thickening in bilateral lung fields. So based on this, the diagnosis, what do you think the diagnosis is? So she's receiving radiotherapy currently. So it's actually a radiation induced lung fibrosis. So why is she having dysphagia? Did you notice something while I was scrolling? So that is an important thing. We'll see the picture again. And now we'll concentrate on the mediastinum. Okay, this is the lung field. This is fine. We are seeing some fibrotic changes in bilateral lung fields, that is post radiation uh, fibrosis that is seen in bilateral lung fields. We have already confirmed that these lesions are not enhancing in the post contrast images. Now we look at the mediastinum as to why she's having dysphagia. So this is the mediastinum, that is the esophagus. Now we can see this artery that is arising in the arch of aorta. That is the aberrant right subclavian artery that we can see arising from the arch of aorta and compressing the esophagus. It is running behind the esophagus. So that is the cause for dysphagia. So the diagnosis here is radiation induced pulmonary fibrosis, which is actually a late manifestation of radiation induced lung disease, and it is relatively common following radiotherapy for the chest, to the chest wall or the intrathoracic malignancies. Hence it was common, more seen on the anterior side of the right lung field in the subpleural region. Other than that, aberrant right subclavian artery was also present, which was actually causing dysphagia. So an important thing to be noted here is we should never ignore the patient's symptoms. It will lead to some diagnosis, and it was an important diagnosis here. So an important complication for of aberrant right subclavian artery is this. So what do you think this is? This is the aberrant right subclavian artery, which I've shown you in this previous images. From the arch of aorta it is arising, and here is dilatation of that particular artery at its origin. So it's actually called a comoral diverticulum, which is actually an aneurysm uh, of the proximal part of the aberrant subclavian artery, and it is actually abutting and compressing the wall of the esophagus and the posterior wall of the trachea. So that is a spotter for you. So coming to our third case, which is case of MRI, where we have a 46-year-old male with chronic back pain, and these are the T1 post-contrast sagittal sections, where we can see that there is intense enhancement along with intraosseous abscess that is seen in the vertebra, along with some paravertebral and anterior epidural extension of the abscess. And this is the report that I had given, that there was post-contrast enhancement with marrow edema involving the lower end plate of L1, L2 vertebra and the right pedicle along with sacral vertebrae, and there was intraosseous abscess also present in multiple vertebrae, and there was bilateral paravertebral abscess also present at L2 level, which was extending into the anterior epidural space causing canal stenosis and cord compression. And the intervertebral discs were relatively spared, so this is very important. Hence I gave the diagnosis of tubercular spondylitis or pot spine. There were some degenerative changes that were also seen in the spine. So how do we differentiate pyogenic and tubercular spondylodiscitis or spondylitis for that matter? So compared to pyogenic infection, tubercular spondylitis has relative preservation of the disc space height. And why is that? Because of two main reasons: that the intervertebral disc, one is avascular, relatively avascular, and the second reason is the tubercle bacilli doesn't have that proteolytic enzymes to actually digest the intervertebral disc material. And the paraspinal abscesses with smooth enhancing wall is typically seen more commonly in tubercular spondylitis. So coming to my fourth case, which is again a case of MRI, So here I saw ring enhancing lesion, this intense enhancing lesion in the in the left high parietal white matter, along with intense perilesional edema. These are the T1 axial sections and these are the T2 axial sections. The T1 section, we can see that there is thick wall, which is also appreciated on T2, along with some hyperintensity, central hyperintensity on T2 that is seen. Intense post-contrast enhancement along with edema. And these are the MRS images where we can see this lipid lactate peak that is seen in the lesion. So this is the report that I had given, that a ring enhancing lesion was seen in the left high parietal white matter with maximum wall thickness of 6 mm, and the lesion exhibited central hyperintensity on T2 with extensive surrounding edema, causing effacement of the left lateral ventricle. There was no restriction on DWI or blooming on GRE, and no similar lesions in the brain parenchyma or soft tissue of head and neck were present. And there was no abnormal meningeal enhancement that was observed. So the lesion demonstrated lipid lactate peak on MRS. So always try to get an MRS done in case of an infective granuloma, because it is always better to differentiate all the ring enhancing lesions at once based on MRS. And the features were suggestive of an infective granuloma, likely a non-caseating. So it is better to give the stage also of the tubercular granuloma and what type of tubercular granuloma it is, whether it is caseating or it is non-caseating. This is actually a non-caseating based on the T2 hyperintensity, central hyperintensity that was seen. Coming to my fifth case, which is an ultrasound case. So here I had done an NT scan. So this is a normal NT scan where the thickness was normal, and this is the normal ductus venosus flow that was seen. So the teaching point here, so the learning points in an NT scan are we have to comment not only on the nuchal translucency but all the other structures that are also very well seen on the mid-sag view. That is the brainstem, the future fourth ventricle or the intracranial translucency, the choroid plexus, the cisterna magna, and then we can comment on the nuchal translucency. And it is very important in case of NT-NB scan. Of course, we look at the nasal bone, which is very well opacified here. You have to look at the echogenic nasal bone. Other than that, we have to always look for ductus venosus flow, whether it is normal and the A waves are normal or not, and the tricuspid regurgitation, which will all indicate right-sided heart failure. Nasal bone presence will actually rule out mid-phase hypoplasia, and nuchal translucency is basically the subcutaneous edema, whether it is present or not. So these are the important things we have to always comment on before actually commenting on nuchal translucency. Coming to our sixth case, so here we have a 30-year-old female with pelvic pain, and there was a lesion that was seen in the right adnexa. These are the color Doppler images, which are not taking any color within the lesion, and this is a grayscale image. So what do you think the diagnosis is? Very clear here, it's a spotter. Mesh-like reticular opacities that are seen, and retractile clot is seen in the right ovary. So it's a case of hemorrhagic cyst. What is the ORAD? So this is a teaching point here, that always try to give ORADs in all the ovarian lesions or adnexal lesions as much as possible on ultrasound. Coming to the ORADs proper, so this is a case of hemorrhagic ovarian cysts, which usually results from hemorrhage into the corpus luteum or other functional cysts. So ORAD 0 is an incomplete evaluation. ORADs 1 is physiologic category, which is seen in normal premenopausal ovary, that is an ovarian follicle less than 3 centimeter or a corpus luteum less than 3 centimeter, has to be labeled as ORADs ultrasound category 1. What comes under ultrasound category 2? So this hemorrhagic cyst is actually was ORAD's ultrasound category 2. So they are all almost certainly benign, that is less than 1% risk of malignancy is there, and it includes a simple cyst 3 to 5 centimeters in size. A cyst about simple cyst about 5 to 10 centimeters in size is also included in ORADs 2. Non-simple with unilocular cyst with smooth margins, non-simple unilocular cyst with smooth margins 3 to 10 centimeter, and lesions with Classic ultrasound characteristics. So we have to know the characteristics of these particular lesions. That is a typical hemorrhagic cyst, a dermoid cyst, an endometrioma, paraovarian cyst, peritoneal inclusion cyst, and hydrosalpinx. So all these are included in ORAD's ultrasound category 2. And it is better to give ORADs while reporting. It will be helpful for the management purposes. So this finishes all our cases of the day today. And the best part of my day is coming back home and spending some time with my grandmother. Okay.